All right, everybody. So we have just a few minutes. I'm really excited to start the conversation about antibacterial therapy. So basically, we're going to be talking about antibiotics, specifically antibiotics. We're not going to be talking about antivirals, antifungals. That's the separate story. So the story of targeted antibiotic therapy starts with Nobel Prize winner Paul Ehrlich, who has discovered in 1909. I mean, we should, give due where it is due. Actually, the compound called sulfasalazine was discovered by his lab assistant, sort of postdoc. It was used to treat the disease known as syphilis, caused by Treponema pallidum. The compound was extremely toxic. It contained arsenic. But people preferred to get all the toxic effects of that treatment, that all the complications of chronic syphilis. But actually, so it was basically poison. We didn't kill the majority of patients, but the first true real antibiotic, the class of antibiotics, was discovered by a team of German scientists. The drug was called penicillin. It belonged to a group of sulfa drugs. They got actually a Nobel Prize for it in 1939. It was the first synthetic antibacterial drug that was used to treat streptococcal and staphylococcal infections. Actually, the rumor has it that one of the scientists' daughter, Domag's daughter, she had an infected wound that she got when she was embroidering. She pricked her finger with a needle and got infection, and nothing could cure it. So Domag, in desperation, tried, I believe it was BASF, the German chemical company. He tried one of the dyes, like the stuff that is used for dyeing clothes, okay? He tried it and it worked, and they kind of kept figuring it out and finally came up with that drug, sulfonamide, which was then developed further into a whole group of antibacterial drugs. The discovery of the first natural antibiotic, penicillin, was done by Scottish scientist Alexander Fleming, who in 1928 noticed that the growth of the fungus Penicillium notatum on the plate of Staphylococcus caused the death of bacteria in the proximity to the fungus. He was probably not the first to see that, but he was the first to make a conclusion that Penicillium notatum was producing some kind of a chemical that diffused away and killed the bacteria. Later, Florian Chain perfected the isolation of penicillin and conducted a bunch of studies showing the effectiveness of penicillin against gram-positive infections. Florian Chain and Fleming all received Nobel Prize in 1945, and duly so, because penicillin saved an enormous number of lives during the World War II. However, as you can imagine, penicillin, eventually microorganisms started to develop resistance to penicillin, but thanks to Dorothy Hodgkin, who established penicillin structure, scientists got the means to modify, to produce semi-synthetic antibiotics, derivatives of penicillin. However, by that time, scientists and doctors still didn't have any drugs that would successfully treat gram-negative infections and mycobacteria. Thanks to American scientist Selman Waxman, who, what's the gain for the United States, the loss for another country, he actually emigrated from Russia shortly after Bolsheviks came to power. He was the Jew from Odessa. Selman Waxman discovered antibiotics, natural antibiotics, in actinobacteria and streptomyces. You still can encounter neomycin, are the drugs in the drug like Neosporin cream, topical cream, antibacterial cream. Some other streptomycin and gentamicin still used in treatment of mycobacterial infections like tuberculosis and some gram-negative infestations. You may notice that I used words like natural, synthetic, or semi-synthetic. So when we use the phrase natural antibiotic, we refer to a drug like penicillin that was derived directly from some kind of microorganism. Like penicillin was derived from Penicillium notatum. When we use the word synthetic, we refer to the drug that was synthesized by humans, like sulfonamides, okay, or chloramphenicol. Those are synthetic antibiotics. Semi-synthetic antibiotics are derivatives of the natural ones. Say you take penicillin and you modify it, turning it into ampicillin or amoxicillin. These two, ampicillin and amoxicillin, would count as semi-synthetic. Antibiotics can be bactericidal or bacteristotic. For instance, penicillins are bactericidal. They kill microorganisms, while tetracyclines are bacteristotic. They don't kill microorganisms. They stop them from replicating, and then our own immune system, basically comes into play and gets rid of them. Antibiotics can differ in terms of the spectrum. Some antibiotics have incredibly broad spectrum of action. Take tetracyclines that have broad spectrum, however, they're usually prescribed for gram-negative infections, or carbapenems that can be used against both gram-positive or gram-negative microorganisms. Now, of course, these antibiotics are prescribed when the actual cause of infection is unknown. When scientists or doctors can establish that the patient has, let's say, gram-negative infestation, narrow-range antibiotic can be used. For example, colistin or polymyxin, or different types of glucosamides. Okay. Now, the main problem with the use of broad-spectrum antibiotics, of course, is the risk of superinfection. When broad-spectrum antibiotics, like tetracycline or carbapenems or clindamycin, are used to treat certain types of infections, they can also knock out some of the normal members of microbiome, say in the gut. If this shifts the balance of microbial abundance in the gut towards potentially pathogenic, say, Clostridium difficile, that leads to what we call a superinfection, when Clostridium difficile overwhelms all other microorganisms in the gut, replicates to abnormal levels, and causes ulcerative colitis. That doesn't have to happen only in the gut. It is very well known that long-term antibiotic treatment may provoke thrush in the mouth, bless you, by shifting composition of oral microbiome, or fungal vaginitis caused by Candida albicans. When antibiotics are prescribed, it's really important to consider the route of administration. Ideally, intravenous route is the best. It allows for the highest concentration of antibiotic in the blood and the tissues, the quickest delivery. You can imagine that IV administration of antibiotic is technically complex. I mean, yeah, it's pain in the ass. If you have a patient in the hospital, that's the way to go. But if you have an outpatient service, you have to put the IV line. It's kind of, a problem, so it's not convenient. So you have to think about bioavailability. And it turns out that some antibiotics can be administered orally. So this blue line shows the bioavailability of the orally administered antibiotic, like amoxicillin. But others can't. Ampicillin. This is the antibiotic that is not prescribed for the oral use. It can be used IV. Okay. You also have to consider, if you want to treat patient with IV antibiotic for a week or with oral for 3 months. Both options are on the table, but you have to think about, possible consequences. Bless you. Does that make sense? Now, finally, it is really important to think about potential, hopefully synergies between different drugs. Well, first of all, I want to make clear, very rarely the patient is prescribed 2-3 drugs at the same time, antibiotic drugs, because they have pretty drastic side effects. So only in case of life-threatening disease, patient will receive maybe a combination therapy, okay? Generally just one. But for some drugs, for instance, for trimethoprim and sulfamethoxazole, the synergy is observed, meaning that each of these drugs separately is bacteriostatic. But when they are combined in the pill known as Bactrim, I bet this name resonates with many of you, these two drugs have bactericidal effect. So they together are much more efficient than each of them separately, and the level of side effects isn't that profound. Does that make sense? So I'm not going to hold you back anymore. On Thursday, we will be discussing the general mechanisms of antibacterial therapy. I want to say that the exam is going to be, let's put it this way, we're going to plan it on Tuesday, but I have certain reservations about our ability to do it on Tuesday. We're probably going to push it back. Okay? We're good? See you Thursday.